Hi everyone, thank you for joining us again for another Facebook Live here at Scottish Rite Hospital. I'm here with Chief of Staff Dr. Dan Sucato in honor of Scoliosis Awareness Month. Welcome again.
Thanks, it's great to be here. This is exciting, second time in 2 weeks.
Yeah, 5 days actually.
Oh, 5 days, yeah, good.
So today we're actually going to talk about early onset scoliosis and really get down to the diagnosis, how we treat it, and different treatments for it, and then also research behind it. So what is early onset scoliosis?
Yeah, so last week, as you said, we talked in general about scoliosis, and early onset scoliosis is essentially based on age. And so there are various definitions, but the basic premise is when you're young, you have a lot of growth left, and so that's what makes early onset scoliosis challenging, because with continued growth, the curve in scoliosis wants to get bigger, and as the curve gets bigger, it's harder to sort of harness that curve. And so you can define it as patients less than 8, less than 6, but certainly any patient less than 8, we sort of put in that category of early onset scoliosis. And so we have a specialty clinic here for early onset scoliosis, and so that's a multidisciplinary clinic with orthopedic spine surgeons, pulmonologists, respiratory therapists, and a number of disciplines that allow us to best take care of those patients, and we'll talk a little bit about why that's really important.
So then how is this diagnosed? Is there a difference between the different causes of it or the different types of EOS?
Yeah, so it gets a little confusing. So if you think of early onset scoliosis as age dependent, so anybody less than, let's settle on the age of 8, is in early onset scoliosis. And then the causes can be from a number of different things. So congenital, they can be born with a abnormal vertebra or many vertebrae that are abnormal with maybe fused ribs. That's a big category. Another category is neuromuscular scoliosis. So children with myopathy, so muscle disease or neural disease. Syndromic patients is another big category. So children with neurofibromatosis, children with Marfan's syndrome, those are sort of syndromic scoliosis. So those are sort of the big categories, and so each of them may be treated a little bit differently because it's dependent on the diagnosis and the risk for progression over time. The reason early onset scoliosis is a little bit different than older patients is that we really start thinking carefully about their pulmonary function, because the pulmonary function is in part directly related to how the chest grows, and the chest grows in part how the spine grows. And so if the spine's growing normally and the chest is growing normally, then the pulmonary function will be normal. If the spine is not growing normally because the curve is, because they have scoliosis, and or they have rib issues and the chest doesn't grow, then we have pulmonary issues. And so those are the things that we really are focusing much more on in the early, younger patients than we are in the older patients.
So you were talking about this multidisciplinary team that these EOS patients come to. So could you walk me through an EOS patient and who they're going to see and maybe the different tests that they're going to go through?
So the clinic, primarily they will see, so the nurses who are very skilled in understanding early onset scoliosis. So again, it's a team approach. So the nurses see the patients initially. The physicians that see the patients are orthopedic surgeons. And the primary surgeons are Charlie Johnson, Brandon Ramo, and Amy McIntosh, so a really skilled team with lots of experience and lots of big interest in this, including research aspects to this. And then we have our pulmonologist, Peter Shockett, who's a pulmonologist who's really outstanding. But what he knows beyond the pulmonary aspect and his expertise is really understand what we do in terms of scoliosis. So it's an integrated sort of comprehensive approach, and Dr. Shockett understands the preoperative, he understands what happens at the time of surgery, and he really understands the postoperative aspect, which really is important to understand. And he's the person that helps make sure that these patients are ready from a pulmonary standpoint for surgery and anticipates any of the challenges that can happen. So those are the physicians. The respiratory therapists also see the patients, so we try to obtain as best we can a assessment of their pulmonary function. In really young children, it's hard to get a formal pulmonary function test, but there's lots of things that they can do with questions and physical exam that will, listening to their lungs, watching how their chest wall moves with respect to breathing, asking them about questions about if they have any pulmonary issues during the school year, during the winter time especially. Those are really important things to figure out.
That's good to know. So then let's get into some of the treatment for EOS. You know, you have the surgical as well as the non-surgical, so maybe we can start with the non-surgical options.
Yeah, so in early onset scoliosis, one of the big categories, I mentioned syndromic, neuromuscular, and congenital. One of the big categories is, much like adolescent, the idiopathic scoliosis, where the child is otherwise healthy, normal, the vertebrae are all normal, there's no underlying neuromuscular conditions. Those patients, if they're young and their curve is a reasonable size curve, we cast them. We mentioned that a little bit last week, but the details of casting are really important. We had Min Mehta, who really developed the methodology for casting. We had her visit here 10 years ago, and we did a couple of patients with casts. And since that time, we've really taken that technique and expanded it, and have been very successful in growing young children straight with casting. So casting is a big treatment modality that we use for certain patients. Bracing is also used. So for those patients who have a little bit larger curves, or for those patients who we've casted and can't grow them perfectly straight, bracing is an option. And the goal of bracing is to prevent the curve from getting any bigger with time. So that's the non-operative side of things. Oftentimes we'll watch small curves. So if small curves are not progressing, that's another sort of treatment arm. It's observation, but it's a non-operative treatment arm. So those are the big three: observation, bracing, and casting.
So then with bracing and casting, does it have to do, I mean, these are young kids, and so they have a lot to do in growing-wise. So does that play a big, function in determining if you brace or if you cast?
Yeah, I think so. And oftentimes, not oftentimes, but when the child are growing, they often will get a brace. Each year they'll need a new brace. Casting, we do sequential casting. So for very young children, we change the cast every couple of months, so that we can continue to sort of mold the cast in a way that will allow their spine to grow straight. So with growth, they'll have new braces and new casts.
So I know another form of treatment that a lot of people are a little hesitant or intimidated by is the halo traction.
Yeah.
So what is that, and what can you tell parents about it and to make them feel more comfortable?
So halo gravity traction is primarily utilized for children who have very large curves. And also, when they have large curves, oftentimes their nutritional status is not optimized because they use a lot of energy. If you have a big curve, it takes a lot to function normally in life with breathing and just activities of daily living. And so oftentimes nutritional aspects are important. They may have pulmonary issues also, as we talked about. And so traction is a great way to take care of all those issues. Traction sounds barbaric, but I have never had a patient and or a family that has had an issue with traction because the child feels better. We put a halo on under anesthesia, and then we start with traction. We have a spring-loaded traction device that was developed by one of our engineers, David Ross, that has been utilized throughout the country, and it is very safe. It's incredibly effective. It's very comfortable. And so children look taller, their chest gets bigger, they breathe easier, their digestive system oftentimes works better, and they come into the hospital, and the family comes to the hospital too, and they can stay for weeks at a time to gain correction. So the more correction we achieve in their pulmonary function in their spine, the better they will be at the time of surgery, which is generally the next step after halo traction.
So you're saying that with the halo gravity, that's just a step before surgery?
Generally speaking, yes. Yeah.
Okay.
Now, sometimes we will use traction ahead of time in very young children where we don't necessarily want to do surgery to loosen up the spine to then put them into a cast to buy some time before surgery is necessary. And buying time oftentimes is the way to go with young children so that we're not taking that next step into surgery, because once you've taken that step, there's sort of no turning back.
So then I know another new technology that a lot of parents are asking about are magic rods.
Yep.
So what are they and how are they used?
So magic rods are a form of growth-friendly rods. And so as a general principle, in young children who are still growing, who have curve magnitude where you think surgery is appropriate, you don't want to do a definitive fusion. You don't want to take the spine and fuse it where it is, or fuse it after correction like we do in the adolescent patient whose spine is slowing down on their growth. And so we try to harness the curve and harness their growth by traditionally putting in the implants and just putting fixation above and below the curve, and then with time, every 6 months, distracting with a small procedure. The magnetically growing rods came along, and it's known as the magic rod. It's a magnetically elongation controlled rod, and the patient only needs one surgery to put the implant in, and then they come back to clinic, and there's a magnetically controlled aspect to the rod that allows you to distract at whatever frequency you want. So the patient comes into the clinic, there's a device that we put on the patient, doesn't hurt, and it lengthens them to whatever designated amount you want to lengthen them. And usually we do small increments over 2 to 4 month period of time.
And so it depends on the patient and their curve on how far apart those different lengthenings
Yes, it depends on how young they are, how flexible their curves are, and other factors. Honestly, I was fairly skeptical about this system when it started to come out, but we've had an enormous success here at the hospital. We probably have the largest North American experience with magnetically growing rods. I just saw a patient in my clinic this morning who had a really challenging curve, and we put his rods in about 6 months ago, and he's doing fantastic. And he's not had more than one surgery, and whereas previously he would have growing rods placed and then growth distraction surgeries every 2 to 6 months.
So then you mentioned the growing rods. So the big difference between those is more surgeries for the patient, and the difference between that and the magnetic.
So the magnetically growing rods are under the umbrella of growing rods.
Okay.
It's just the way they grow is different than the traditional way, in which you had to go in and do surgery every 2 to 6 months, whatever your growth, whatever your distraction rate is, to continue to follow the spine and grow the spine with the patient. Whereas the magnetically growing rod, they just come to the clinic for the distraction as opposed to go to the operating room. So it's really been a game changer.
Yeah, definitely. So I think another section of what's really important is the research. I mean, this hospital, we're world renowned for it. So what research is happening in spine for scoliosis, and how has it really helped the care of patients here?
So research is one of our fundamental pillars at the institution: clinical care of patients, education of the next generation, and then research. And research really, to me, it answers the sort of challenging, unanswerable questions we've had with time. It's sort of the engine that drives decision making. So when we see patients and we have a question, the next step is how do we answer that question, and research is the answer. And so specifically for early onset scoliosis, we have an ongoing prospective study. It's a registry of patients that every patient that comes to the hospital is enrolled in the study. And it's not the patients aren't enrolled to sort of decide, are we going to do this treatment or this treatment? They're simply enrolled so that we can study their progress over time in a research way. It doesn't change what the decision making is. It helps us understand what those patients do over time, which treatments may or may not be as effective as others. And so every patient is studied very well when they come in with good physical exam, good history, specific imaging studies, specific questionnaires that are given to the family to say, how do you think your child is today? So that in 6 months, 1 year, we can say, how do you think your child is tomorrow? The x-rays may look good to us, but if the patient's not doing well in the eyes of the patient and the parents, then we need to really understand that, because ultimately that's the goal, is to make the patient happy and make them satisfied and give them good health status. And that's the best way to answer that question, asking them how they're doing.
That's wonderful. So I think we have time for one more question.
Okay.
So I think we're going to look into what are some of the medical tests that some of these kids can expect to go into. CT, MRI. I know we have a nice model of a spine to kind of help determine what type of surgery, when you have surgery, what it is that you're looking at.
So when children come, the first thing, we touched on this a little bit last week, is just getting a good history and a good physical exam. And then standard radiographs are good. And we talked about our EOS system, which children, if they're 6 or older, are generally put into the EOS machine, which is a low radiation. You can get an AP and lateral X-ray, a front view and a side view all at the same time, and you make a 3D model of the spine too. And then oftentimes in young children, we really want to understand the spine really well to the sort of small level, and we'll get a CT scan. And fortunately, we have a 3D printer at the hospital. We've had it for the last 7 or 8 years. We were sort of ahead of the curve with respect to that. And we can make models like this. So this is a young lady who had a pretty large curve, and we made a 3D model from her CT scan. And you can see that this is, I'll point this at the camera, that this is looking at the patient from behind, and so they had a right thoracic curve, and you can see the ribs which have been sort of cut off. This is a model in which we just really focused on the spine, had a right thoracic curve, and you can see that we can see all the specific vertebral bodies and the vertebra and the shape of the vertebra, and then the overall contour of the scoliosis. And if we turn it in this direction, you can see the vertebral bodies. You can see a little bit of wedging that's happened here with the spine. And so this really allows us to, for this particular young lady who I've done surgery on, I can look at this model and really understand her spine before the surgery's done, and sort of do the surgery in my mind before we actually do the surgery at the time of her procedure. So this young lady actually had a congenital scoliosis, and you can see that these vertebrae are all shaped rectangular, but this vertebra has a little bit of an extra hemivertebra attached to it, and so that's the apex of the curve, and so with that hemivertebra, it's tilted her spine in a way that created the scoliosis, and with growth, it really took off. So this young lady also had an MRI to study the spinal cord, because congenital scoliosis can have spinal cord abnormalities, and so it's really important to understand that ahead of time. So that's all done at the same visit. Certainly the CT scan. MRI oftentimes has to be scheduled because they oftentimes need anesthesia for that. It's very well orchestrated visit. There's usually no blood tests, so children don't have to worry about needles when they come. So it's pretty benign.
Good. Well, I think that's all we have time for today. Thank you for joining us for another Facebook Live.
Well, thanks for having me. It's been great.
Definitely go visit our website, scottishridehospital.org, or if you have more questions, put it in the comments below.
And we'll be quickly sure to answer those questions.
Thank you.
Thanks.